Good morning, everyone. My name's Casey Bro, if you didn't already know, and I will be discussing Chapter 10, which involves fiscal planning. First off, I'd like to say that I do apologize for sitting in a chair. I am by myself in the comfort of my own home. I also apologize for not having you be able to view the PowerPoint while I talk. I was going to use my iPad, but I'm apparently behind on the times and don't have an iPad charger, so I'm going to put that to the side, and we're going to go ahead and get started. Chapter 10 discusses the leader and manager's roles in fiscal planning. It identifies types of budgets and delineates the budgetary process. So, healthcare organizations are continually faced with financial challenges due to shrinking reimbursement and rising costs. Nurses are practicing an environment in which the economics and costs of healthcare permeate discussions and impact decisions. With that being said, page 205 of our text states that regulatory costs have tightened, quality expectations continue to rise, and the public is increasingly demanding higher services at little to no out-of-pocket costs. So what is fiscal planning? Fiscal planning is not intuitive. It is a learned skill that improves with practice. It requires vision, creativity, a thorough knowledge of the political, social, and economical forces that shape healthcare. There is some fiscal planning for you on pages 209 and 211 of your textbook in Display 10.2. I highly encourage you to look at those. Throughout my discussion today, I will be using some of these terms. So it would behoove you to familiarize yourselves with these terms. I was going to have us do a little project. It's for leadership and management in fiscal planning. There are different aspects to incorporate. On pages 206 and 207 of your text, however, I highly encourage you to look at these sections. They do provide you with a great deal of information involving this. So balancing cost and quality. Cost containment and quality of care do not always have a linear relationship. Cost containment is the responsibility of all healthcare providers. It is the effective and efficient delivery of services while generating the needs, revenues for continued organizational productivity. In healthcare, cost and quality do not have a linear relationship. Higher spending does not always mean higher quality of care. So with that being said, higher spending may be the result of a duplication of services and overutilization of services and the use of technology that exceeds a particular patient's needs. Responsibility accounting and forecasting. Responsibility accounting, each of an organization's revenues, expenses, assets, and liabilities is someone's responsibility. An essential part of fiscal planning is responsibility accounting. This responsibility typically falls on the manager. The leader manager should be an active participant in unit budgeting, have a higher degree of control over what is included in the unit budget, and receive regular data reports that compare actual expenses with budgetary expenses, and be held accountable for the financial results of the unit. Forecasting is making an educated budget estimate by using historical data. Because the manager is directly involved in the unit's functioning, they should be easily able to forecast patient trends and supply needs. So the basics of a budget. Budgets are financial plans that include estimated expenses and income for a period of time. Planning a budget requires flexibility, ongoing evaluation, and revision. So in regards to budgeting, Dan Bennett states that the trouble with a budget is that it's hard to fill up holes without digging another. Accuracy of the budget dictates the budget's worth. The value of the budget is directly related to its accuracy. The manager is responsible for communicating budget planning goals related to the staff and relaying them to the staff. A budget prepared too far in advance may leave greater room for error. The better the staff understands, the more likely the goals will be obtained. So another thing to understand is that expenses in a budget may be fixed, meaning that they do not vary with volume, or they may be variable, meaning that they do vary with volume. So let me ask you, can someone give me an example of a controlled expense? I'm jumping ahead. Can someone give me an example of a fixed expense? What about a variable expense? There will be an opportunity for you to provide your answers on Blackboard, and we can discuss them now. So a fixed expense might be a building's mortgage, payment of a manager's salary, those sorts of things. Variable expenses, however, might be hourly pay, wage employees, and the cost of supplies. Controllable expenses can be controlled by the manager, whereas non-controllable expenses cannot be. I'll pose the same question now. What are some examples of controllable expenses? How about non-controllable expenses? I'll also provide an opportunity for you to relay your answers in Blackboard. Some examples of a controllable experience might be the number of personnel working, whereas non-controllable might be equipment depreciation, the number of types of supplies needed by patients, and overtime work related to an emergency. The next thing I'm going to discuss with you is steps in a budget process. These can be found on pages 208 or 212 of your text. Let me start by asking you, how many of you have been broke as a joke and really just debated on selling your plasma? I know I have. So it's pretty important to know how to budget, whether you're in a management position or in a life position. So with that being said, here's an acronym for you to remember the steps of a budget process. ADPIE. Add dollars, please. I'm empty. The A for assess, D for diagnose, P for plan, I for implementation, and E for evaluation. So A, assess. The needs to be covered in the budget. Assessment should include input from all levels, since budgeting is most effective when all are involved and understand the process. A composite of needs, including labor, equipment, and operative expenses, are a few things that can be included. Diagnose. Diagnose the goal, what needs to be accomplished. Create a cost-effective budget, maximizing the use of available resources. Being cost-effective means producing good results for the amount of money spent. In other words, the product is worth the price. The third step to develop a plan. According to page 211 of our text, most budgets are developed for a one-year period. However, selecting the optimal time frame is extremely important. Again, this is why it is important to be flexible with budgeting. In order to implement the plan, page 212 states that ongoing monitoring and analysis occurring to avoid inadequate or excess funds. This is why monthly statements are prepared. Monthly statements outline the department's projected budget and possible deviations from that budget. The last step is evaluation. In this step, the budget is reviewed and modified throughout the year. Managers are held accountable for budget deviations. Now I was going to have each of you create a budget, but unfortunately, we're not in class, so I'm going to post a link on Blackboard along with my other links for you to practice with this. Adulting is really hard, people. We probably could all use some help with budgeting. So types of budgets. There are three types of budgets. We have the personnel budget, the operating budget, and the capital budget. The personnel budget is the largest of the three. Page 212 of our text states that healthcare is a labor-intensive. Managers use historical data about unit census fluctuations in forecasting short and long-term personnel needs. In addition, they must monitor the personnel budget closely in order to prevent understaffing and overstaffing. So as patient days and volume decreases, managers may also decrease personnel costs. Also included in this budget is the staffing mix of licensed versus unlicensed personnel and their needs. Most staffing is based on a predetermined standard. Staff may increase or decrease in volume as patient volume fluctuates. So thinking about the emergency that I work in, for example, we're required to have a certain number of emergency room technicians and the licensed registered nurses. That being said, this number may fluctuate based on budgeting, the budget cuts that nobody likes to talk about, and it might also be based on patient volume fluctuation. Sometimes I'll be flexed in or flexed out of work because of those sorts of things. So that being said, staffing needs can be determined by the formula shown, or not shown because you can't see the computer. There's a formula I'll include later for you. It's NCH divided by PPD, which equals nursing hours worked in 24 hours over patient census. An example of this type of problem is provided for you on pages 213 and 214 of your text. I highly encourage you to go ahead and look at that. So the second type of budget we're going to discuss, the operating budget, reflects expenses that change in response to volume services. Page 214 of your text provides examples of this, including the cost of electricity, repairs and maintenance, and supplies. Managers should keep track of this type and amount of supplies used in their units. Considerations might include the patient mix, technology requirements, and types of procedures typically performed. There are many ways to reduce supply costs listed on page 218, but one way I find most important is the just-in-time ordering. These orders are delivered only when supplies are needed and immediately before they're being used. So the last type of budget, the capital budget, includes purchasing of major equipment that has a life longer than, let's say, greater than 5 to 7 years, not used daily, and are more expensive than supplies that are typically used in your unit. They are composed of a long and short-term component. Examples of long-term components might be something like the renovation of a pretty well-established hospital wing, whereas a short-term component might be some hospital beds. In order to be considered capital equipment, the equipment requested must exceed a specific dollar amount. This varies from hospital to hospital. Equipment request forms can also be submitted by managers in order to justify the request. However, certain budget busters might come into play. These can be found on display 10.3 of your text on page 216. Words are hard. So budgeting methods, there are 4 of them: incremental budgeting, zero-based budgeting, flexible budgeting, and performance budgeting. To determine incremental budgeting, you multiply current year expenses by a certain figure. This figure might be inflation rate or consumer price index. This determines the projected budget for the upcoming year. And according to page 216 of our text, although this is the simplest of the 4 methods, it is generally insufficient fiscally because there is no motivation to contain costs and no need to provide programs and services. In zero-based budgeting, managers must re-justify their program and needs before every new budgeting cycle. This does not mean that the program funded previously will be funded again. So this is labor-intensive for the nurse managers. The use of a decision package to set funding priorities is the key feature here. Display 10.4 on page 216 of your text includes 4 components of decision packages. So I also encourage you to look at these. As well as on page 216 and 217, there's an example of how this might be utilized. The last thing I want to say about decision packaging and zero-based budgeting is that they force managers to set priorities and use resources more effectively and efficiently. Page 217 of our text tells us that flexible budgeting includes those that flex up and down throughout a year depending on volume. They automatically calculate what expenses should be given and the volume occurring. This works well in healthcare settings due to the ever-changing census and staffing needs, both of which are difficult to predict even through historical forecasting. Last budgeting method I'm going to discuss with you is performance budgeting. Page 218 states that performance budgeting emphasizes outcomes and results rather than activities and outputs. This means that the manager would budget to achieve specific outcomes and evaluate success accordingly. An example of this would be a home health agency establishing an outcome for a particular group of people, such as patients with diabetes, and determining the budget based on their needs. Critical pathways. Critical pathways are strategies for assessing, implementing, and evaluating the cost effectiveness of patient care. Predetermined courses of progress patients should make after admission for a specific diagnosis or procedure might also be a part of critical pathways. If a patient's progress differs from that of the critical pathway, prompt variance analysis is necessary. Another part of this might be providing a useful tool for monitoring quality of care. Once the cost of a certain pathway for care is known, analyzing cost effectiveness and cost variance is possible. Decisions can be made based on both clinical and financial outcomes. Now, there are some benefits versus weaknesses to critical pathways. Some benefits might include standardized care for patients with similar diagnoses, whereas weaknesses might include that it may be difficult, accounting may be difficult for and accepting who have justifiably deviated from their pathway, and documentation increases the workload in a system already burdened with administrative costs. The last thing I'm going to discuss with you is healthcare reimbursements. Reimbursement was based on costs which provide services and profit with no limit placed on the total amount that the hospital can be charged. According to page 218 of our text, because insurance carriers reimbursed fully on virtually a limitless basis, there was little motivation to save costs, and organizations found it unnecessary to justify charges. The end result of uncontrolled FFS reimbursement. Under FFS, the more services provided, the greater the amount that could be billed. This encouraged over-treatment of patients. That being said, the U.S. spends more of its GDP on medical care than any other nation in the world. So that's all I have for you, and we're going to move on